So welcome to this seminar on musculoskeletal history and examination by Dr. David Harness. Today we're going to focus particularly on the shoulder and the knee joints in terms of specific related questions to the history, considering differential diagnoses like orthopedic problems, as well as rheumatological or systemic conditions. Then we're going to look at some specific shoulder and knee examinations, and we're going to do this all through clinical case studies. Take, for example, case 1, where you have the 54-year-old electrician who's been experiencing pain whilst at work when kneeling down. So it's been affecting his work. He can't kneel down easily because of pain. What questions would you ask him? So what questions, particularly of the knee, are relevant, specific questions in terms of his pain, in terms of other symptoms, and also in terms of function. And then thinking also what questions to increase the differentials of what other possible causes could there be. So once you take a history, you find out it's had no trauma or injury. It's particularly on the front of the knee, anterior. There's no pain in the groin, or the hip joint, or the ankle. It's always good to ask about joint problems above and below the current joint you're looking at. Is there any swelling? Yes, there is some swelling at the front of the knee. Does the knee ever give way when walking or standing? Do you ever get any falls? No, it's not giving way. Does the knee ever lock, as in get stuck when bending it? You have to almost release the leg manually. Again, there's no problem with that. Is there any stiffness? No. Is there any other joint involvement? No. How is it affecting his life? It's painful to kneel down for his job, and when he's praying particularly. It's okay when he's walking and doing other activities. So specific questions that are useful to ask related to the knee. Always ask if there's been any trauma currently or in the past. Where exactly is the pain? And people can localize pain with the knee, whether at the front, the lateral or the medial side, or even behind the knee. Like I said, always ask about nearby joints. Could be any referred pain. People experiencing knee pain, sometimes it can be due to an osteoarthritis of the hip, for example. It's not actually a problem in the knee, but it's referred pain. Is there any swelling? Again, is that gradual or sudden onset? Is the whole joint swelling, or is it a localized swelling around the knee? Is there any stiffness? Could this be of muscular origin or a sign of arthritis? When walking or standing, is there any instability? Does the knee give way when walking or standing? Particularly thinking about a cruciate ligament problem. And does the knee ever lock, get stuck when bending it? You can get meniscal tears that can lift into the joint space, and so that locks the knee when it's bent. Here we've been talking about anterior knee pain, and think about the structures of the knee in terms of the anterior part. You've got the quadriceps muscle that comes over the femur and inserts in the tibial tuberosity. This is a place where you can get inflammation and pain, very specific over the tibial tuberosity, something called Osgood-Schlatter's disease. You also have the patella that can cause pain if it's misaligned, it's going in the wrong direction, or maybe it's rubbing against the femur. You can get patellofemoral arthritis. You also have anteriorly, you have the anterior cruciate ligament that could be inflamed or sprained. And these blue circles that are the suprapatellar bursa, the prepatellar bursa, subcutaneous infrapatellar bursa, the subsartorial bursa. These bursa are all fluid-filled sacs, and they help the muscles and the joint move smoothly over other structures, but they also can get inflamed and cause localized swelling and pain in the anterior part of the knee. And that's what's going on in this case. This electrician, his prepatellar bursa has become inflamed, so it's very difficult to kneel directly onto his knee. So when thinking about anterior knee pain, we mentioned Osgood-Schlatter's disease. This is the problem where it's inflamed just where the quadriceps tendon inserts into the lower tibia, the tibial tuberosity. Common in teenagers, lasts for a few months, and then tends to disappear again. We talked about the patella. You get misalignment, or particularly the tendon of the quadriceps going over it can cause pain. Prepatellar bursitis, this is the inflammation of the bursa, particularly when somebody kneels down to pray, or the work we've just mentioned. We talked about arthritis as well, the patellofemoral joint. A diagnosis of exclusion, once they've excluded other things, it can be patellofemoral pain syndrome. There's nothing organic that's obvious. You can get the collection of symptoms due to that area. Also, you can get referred pain from the hip, osteoarthritis of the hip, or Perthes disease. And then we get into the arthropathies. Could it be an arthritis, gout, or rheumatoid arthritis, or even septic arthritis, infection of the joint? So you may also want to ask about other joints that may be involved, any morning stiffness with rheumatoid arthritis, any fever, thinking about septic arthritis, looking at anterior cruciate ligament sprain or tear. Is there any instability of the knee? Was there any popping sensation or sound that could relate to a possible tear? So these are all things to think about when looking at the anterior knee. Also, think about the lateral and medial aspects of the knee. For example, if you look at the medial aspects, you can see that possibly it could be a MCL sprain, medial collateral ligament that comes around the side of the knee. Also, you've got the medial meniscus inside the joint itself, or arthritis of the two joints, the femur and the tibia could be just medial arthritis of the joint. When thinking about lateral problems, you could have iliotibial band syndrome coming down from the hip, the iliotibial band, particularly runners get this, or lateral meniscus tear or sprain on the other side of the knee coming from the lateral aspect. Again, you can think about lateral meniscus problems on this side. If you're talking about inferior to the patella, you've got patellar tendonitis, Osgood-Schlatter's, and other types of problems. Okay. So in this photograph, on inspection, you can quite clearly see that this knee is quite swollen above the patella compared to the other knee. This is typical what you get in prepatellar bursitis, quite defined margins of the bursa. It's a little bit red and angry and swollen. This isn't a joint effusion. This would be into this area of the patella on both sides. This is above the patella, so this isn't a joint effusion itself. You're going to obviously palpate, superior, inferior, particularly tibial tuberosity, go along the joint line, the lateral side and the medial side, go around the patella, palpate there, and also look on the back of the knee, particularly in the popliteal fossa, to see if there's any Baker cysts or swelling there when you're doing the inspection. You may need into some scarring, some deformities, possibly a rash, or localized or generalized swelling. If you want to decide whether this is a joint effusion, then what you tend to do is milk your hands, your left hand down over the quadriceps to push the fluid down underneath the patella, and then you can do a side sweep on one side to see if there's a bulge of fluid going in the other direction, or you could do a patella tap where you tap on the patella and it pushes down onto the fluid and then comes back up again because the fluid pushes it back up. Let's talk about another case. This time we have knee pain secondary to trauma. So an 18-year-old gymnast has been practicing on the high bar and has fallen, jumped awkwardly onto a mat. This has happened just 2 hours ago. You're seeing her in the emergency department. What questions would you want to ask? So again, she fell directly onto her foot, and it's no twisting injury. She just fell onto it. The pain is all around the knee. It's very severe. It's actually quite sharp, now throbbing. There was a pop sound heard before the pain happens. What about swelling? Yes, it's very swollen, and that started quite quickly within the first hour. Can she weight bear? No, she can't. Is there any locking of the knee? That's hard to tell at this moment. It's too early, it's too painful and swollen even to weight bear, so it can't tell. Does the knee give way? Again, hard to tell, as she can't weight bear. So when thinking about specific questions related to trauma to the knee, you want to know what was the mechanism of injury. When she fell, did she twist her knee? Did she fall directly onto the knee? Was it a side tackle in football? That could possibly lead to a medial lateral collateral ligament sprain. So what exactly has happened in the injury? Can she weight bear? Can you weight bear on that leg? Could there be a fracture possibly? Where exactly is the pain? Again, is it anterior, lateral, medial, posterior, or the whole knee? Is there any swelling? And if there is swelling, how quickly did this happen? So if it's happened in the first hour, then you're thinking about possibly blood into the joint, a hemarthrosis, particularly with a cruciate tear, or has it happened several hours after the injury, or osmotic the effect, which can be due more to do a meniscal tear or injury. And again, where is the swelling? Is it a localized swelling over a bursa, or is it a joint swelling within the joint? There's a problem in the joint. Again, you want to ask, does the knee give way when walking or standing? Is a loss of stability secondary to a tear of the cruciate ligaments? Does the knee ever lock, get stuck when bending it, such as a meniscal tear? Or you can get foreign bodies, particularly from arthritis. Part of the bone can come away and cause locking of the knee. So don't forget about the structures of the knee and the cause of the pain or swelling. And think about the mechanism of injury. So if it's a side tackle in football, you could have sprained the lateral collateral ligament or the medial collateral ligament, particularly if there's pain in these two areas. If it's been a shearing or twisting injury, like a shearing force that twists, then that could be a meniscal problem that particularly causes tears of meniscus. A quick change in direction, maybe it's going fast in one direction, change direction, and that twisting motion, or the foot gets stuck in the mud, and it maybe gets twisted in a tackle, then that can cause a meniscus problem. If it's a direct fall from a height, that can potentially snap the anterior or posterior cruciate ligaments, and that causes swelling quite quickly. So you consider the structures of the knee and what could have gone wrong in terms of the mechanism of injury. So in this case, the person felt a pop or a popping sensation, quite loud noise. It's developed really severe pain, unable to carry on doing even standing or carrying on with activities. Often with an anterior cruciate ligament tear, there's usually a sharp pain initially, and then it becomes more of an ache, throbbing pain. Pain often is quickly associated with swelling. In the first hour after the injury, you get blood, hemarthrosis into this joint. So remember that a knee joint is avascular, it has no blood vessels in it, but a tear can then bring bleeding into the joint, particularly from the anterior cruciate ligament. Versus rapid swelling versus slow swelling that happens hours after an event or a trauma, that's more likely to be a meniscal tear. After the pain and swelling eases after several days, and when the patient starts walking on the knee again, they may notice that it gives way. The stability of the knee has been lost, and that's because of The anterior, the posterior cruciates give stability to the knee, hold the knee together. So now we get into testing the collateral and cruciate ligaments as well as the menisci. The test for the collateral ligaments, you're going to be sitting on the side of the bed, holding the lower leg in between your elbow and side of your body. You put one hand on for example, if you're testing the medial collateral ligament on the right leg, you'll have your lower right hand on the calf, the inner side of the calf, the medial aspect of the calf. You'll have your left hand on the upper thigh, on the lateral aspect, the outer side of the thigh, and you push quickly in opposite direction and test the medial collateral ligament. You swap your hands around, and again you then move your left hand down to below the knee on the outer aspect of the calf, and your right hand will be on the inside of the thigh. Again, you push quickly to test if there's any pain or any laxity of the lateral collateral ligament. When looking at the cruciates, you want to flex both knees and look at both from the side to see if there's any sagging of the knee. Could there be loss of integrity of the posterior cruciate ligament? Then you're going to do the anterior draw test and the posterior draw test. So you're pushing down with your thumbs on top of the tibia to see if there's any laxity, any weakness, and then you're pushing with your hands behind the lower leg, pushing upwards to see if there's any laxity of the anterior cruciate ligaments. Test the meniscus, there's two different ways. One is the McMurray's test, where the patient's on their back. And the one I prefer is the Apley's compression test, when the patient's on their front. The reason why I like Apley's compression test is, number one, you can look at the popliteal fossa for any swelling. Secondly, I find it an easier test to do. So it's like pushing down with your hands on the sole of the foot and twisting like in a pepper pot. You push down and twist one way, push down and twist the other way, to see if there's any pain or any cracking sensation as you do that. And you stabilize the leg by putting your knee on the thigh. So here is an MRI scan, and you can see this more white area inside the joint space. Again, it's more brightly coloured on that side, and this is a meniscal tear and an MRI scan. MRI scans are much better at picking up soft tissue injuries like meniscal tears than an X-ray. The tear is typically like the look of a handle on a bucket, so that's why it's called a bucket handle tear. And this tear, this bucket handle, can go up into the joint space and cause locking. So now we're going to look at another case, a case of a 55-year-old woman who has a painful shoulder. She has developed right shoulder pain and stiffness. What other questions would you ask her? Again, like with any symptom, it's always worth knowing, when did it start, how long has this been a problem? It started about 3 months ago. It's gradual onset, there's no trauma, it's constant, it doesn't go away, particularly affecting the sleep. Is there any stiffness with the pain? Yes, there is. And how has it affected her? In what ways has it affected your normal tasks and everyday living? For example, washing, dressing, or combing your hair. Overhead activities. So yeah, it's affecting all those things in washing, in dressing, combing her hair, and it's difficult to move her arm in all directions. Is the other shoulder okay? Yes, it's fine, there's no problem with that one. Any joint pains elsewhere? No, there isn't. One of the major differences between people experiencing shoulder pain and knee pain is the difficulty people have in exacting where the pain is. Where exactly is the pain? So shoulder, generally people just point to their deltoid area, but there's many reasons why they can get pain in this area referred pain. Also, maybe people talk about in the shoulder tip area, they're getting pain in the shoulder tip, and it may be unrelated to the acromioclavicular joint, and it's another problem going on. So always think more widely with shoulder pain. Think about what could refer into the shoulder and be causing the pain. For example, myocardial infarction. So somebody's having a heart attack or angina pain. Is it associated with chest pain, this shoulder pain? Does it come on with exertion? Again, like with the knee, think about the joint above, here with the neck, the cervical, lumbar vertebrae, and also the nerves that come out, disc problems or nerve-related problems. And so I tend to tell all medical students and doctors that the shoulder examination should also include a cervical spine examination. Just quickly check over the cervical spinal processes, check neck movements. Could it be related to the neck at all? Remember the phrenic nerve that comes from the diaphragm going up to the shoulder. So anything that excites the phrenic nerve, either it be gallbladder disease or a subphrenic abscess, could be experiencing, the patient could be experiencing shoulder tip pain, and that's secondary to phrenic nerve irritation. So again, you may want to ask questions about if you've got any abdominal pain, any fever, any nausea, vomiting when you eat fatty foods, for example. So you just want to check for that. Also, if somebody smokes, if this is a 55-year-old woman who smokes, you want to just make sure there's no other symptoms, lung-related symptoms, like hemoptysis, cough. Could it be a lung cancer causing the shoulder pain? Sadly, I had a colleague who missed a lung cancer because they thought they had a shoulder problem, but it wasn't a shoulder problem, it was a lung cancer. The other thing I think is helpful to consider when looking at shoulder-related problems is the age of the patient and what things are more common in that age group. So in this case, we have a 55-year-old lady, so it's less likely she's got a shoulder dislocation. She's over 40 years old. It's also less likely at the moment that this is osteoarthritis or rheumatoid arthritis. She's not over 60. That's more common in the over 60s. Again, it's unlikely she has a calcified supraspinatus tendon. That's more common in 30 to 40-year-olds. However, she could have rotator cuff disease, whether that be a tear or a sprain. She could also have frozen shoulder, the beginnings of frozen shoulder. Again, if it's both shoulder affected with stiffness, she could have polymyalgia rheumatica, which is a rheumatic condition affecting the muscles. So we're going to just talk about shoulder inspection and palpation. It's going to take you on a journey in terms of doing a shoulder inspection. So this slide is just to remind you of the shoulder anatomy, the surface anatomy landmarks, as well as the particular parts of the shoulder underneath. So here we have the sternoclavicular joint, the clavicle, the AC joint, the acromioclavicular joint, the glenohumeral joint, and the crocroid process, which is just about 2 centimeters medial below the acromioclavicular joint. Here is the inside, what's going on. Here you've got the clavicle coming above. This is a posterior view. The tendons between the acromion and the clavicular point, and then the crocroid process is down here, and then this is the glenohumeral joint, where you're going to go into the shoulder itself when you're palpating. Often you want to look for any asymmetry of the AC joint. Could there be a dislocation? When looking for dislocation of the glenohumeral joint, you need to look at a sideways approach. So always look from the front, the side, and the back posteriorly to look at the scapula and in muscle wasting as well. Like I say, you need to expose both shoulders. You need to look at the front, the side, and the back. When looking at the front, any deformities is an asymmetry. Is the clavicle elevated compared to one side? Could there be an AC joint dislocation? Obviously, best at the side to look at the glenohumeral. Is there any anterior-posterior dislocation? Any swelling, any bony swellings or possible fractures, inflammation, any redness, again any masses, any rare bone tumours you may notice. Muscle wasting. Again, you look at the deltoid bulk, the big abductor of the shoulder. Again, from the back, looking at the supraspinatus and infraspinatus posteriorly. If the tendon's torn, then you get loss of usage of the muscle and wasting begins to happen. Also look for any scapular winging of the scapula, and you may augment that by asking the patient to put their hands against the wall to look for any winging of the scapula, and that's due to paralysis of the serratus anterior nerve. Palpation begins with a journey. So you start at the sternoclavicular joint medially, palpate along the clavicle laterally until you come to the AC joint. Is there any tenderness? Is there any laxity? Is there a possible fracture or dislocation? Then you palpate the acromion and the coracoid. So you're going to go 2 centimeters below and medial to the tip of the clavicle. Move to the bicipital groove to palpate the biceps tendon. If you're not sure where to locate this in a big shoulder, ask the patient to clench their biceps, and you should feel the tendon being utilized. Again, just to check the supraspinatus and tendon, ask the patient to extend the shoulder backwards to extend it, and then palpate over the tendon from behind the patient to check for any tenderness, any tear that you may not even feel the tendon moving. Also in palpation, you're going to check all the borders of the scapula for any tenderness. This is just a slide to show how you palpate the supraspinatus tendon. So just going back to this 55-year-old woman who had the onset of painful shoulder over the last 3 months and finding it difficult to move in all directions, affecting all her activities of daily living, continuous pain, worse at night. This lady is typical of someone beginning with frozen shoulder, with pain, severe pain. It's continuous, it's quite a throbbing pain, and also you get reduction in all movements of the shoulder. Particularly in the beginning though, it's external rotation of the shoulder, that's what's difficult. So she's probably going through the freezing stage in that first 2 to 9 months. The loss of mobility is beginning now, and sadly that can really restrict the amount of movement the patient can get from the shoulder. Thankfully, it does often resolve, but it can take months to years. So typically 1 to 2 to 3 years, and the condition can resolve. It's more common with diabetes and hypothyroidism. And this will end the first part of this seminar, and then we're going to look at some more cases in part 2.